Before menopause, a woman's body actually produces 3 times as much testosterone as estrogen. I mean, 3 times.
Yeah, which always surprises people.
Right. Yet, when midlife hits and a woman's sex drive just seemingly vanishes overnight, we really only ever talk about estrogen. Or, honestly worse, the medical community just doesn't talk about it at all.
Oh, the silence around this specific symptom it's staggering, really.
Yeah. Yeah.
Because it is relatively easy to joke with your friends about, night sweats or brain fog. But when desire completely flatlines or,
Ugh.
or when physical intimacy suddenly becomes excruciating, that conversation just completely shuts
It
down.
becomes this massive taboo.
Exactly. And that lack of understanding leaves so many people feeling, well, broken. Or they get convinced the relationship is failing when what they're actually experiencing is a highly predictable cascade of biological events.
So, today we are bringing that conversation out of the shadows. For this deep dive, we are taking a stack of rigorous clinical guidelines. We're talking direct from the British Menopause Society, the NHS, and the Royal College of Obstetricians and Gynecologists.
Heavy hitters.
Yeah, the real evidence. And we're going to decode exactly how declining estrogen and testosterone affect your sex drive and your libido. Our mission here is to just strip away the emotional baggage and look at the actual mechanisms at play.
Which is so needed.
And most importantly, we are looking at the evidence-based roadmap to get that desire back. So, okay, let's unpack this because we cannot talk about libido without first looking at the physical environment where it all actually happens.
Right. And if we connect this to the bigger picture, libido isn't just a single switch in the brain that accidentally gets flicked off.
It's not just like, oh, I'm not in the mood.
No, not at all. It is an incredibly complex interplay of your physical tissue health, fluctuating hormones, and your psychological environment. So, to really understand the loss of desire, we have to start by looking at what the medical texts now call genitourinary syndrome of menopause, or GSM.
I noticed that actually. The guidelines have moved away from that old term, atrophic vaginitis.
They have, yeah. Primarily because the estrogen receptors aren't just located in the vagina. I mean, they are densely packed throughout the entire pelvic region. So the urethra, the bladder trigone, the pelvic floor muscles, they're everywhere.
Wow.
And during your reproductive years, estrogen acts as this foundational nutrient for all those tissues.
The sources go into fascinating detail about the microscopic level here. Like, it's not just that the tissue gets a bit dry, the entire ecosystem basically collapses.
It really does.
I was trying to visualize this, and it reminded me of like a coral reef's reliance on sunlight. You know, when the nutrient source vanishes, the ecosystem bleaches, the native species starve, and then these hostile invaders just take over.
That is actually a remarkably accurate way to describe the vaginal microbiome, because a healthy, estrogen-rich vaginal wall is highly dynamic. The
Mhm.
superficial epithelial cells, they plump up and they constantly shed.
Right.
And when those cells die and slough off, they release glycogen into the vaginal canal. That glycogen is the primary food source for lactobacilli, which are your beneficial protective bacteria.
And then the lactobacilli eat that glycogen and excrete lactic acid, right? Which keeps the whole environment acidic, usually at a pH around like 3.5 to 4.5.
Precisely. Which is an incredibly hostile environment for bad bacteria.
So it's protecting you.
Yes. But when you remove the estrogen, that entire self-sustaining loop just crashes. The vaginal walls become remarkably thin, the cells stop shedding, which means the glycogen completely disappears.
And without the food, the protective lactobacilli die off.
Exactly. And then the pH of the vagina actually rises above 5. It becomes less acidic, which is why women in perimenopause and menopause suddenly experience this huge surge in recurrent urinary tract infections or thrush.
The biological shield is just gone.
It's gone. And structural changes happen too. The vaginal tissue loses its rugae. Those are the natural sort of accordion-like folds that allow the tissue to stretch and expand.
Yeah, the medical texts describe the resulting tissue as friable.
Friable, yes. It becomes so fragile that just the simple friction of intercourse causes microtears and bleeding. I mean, it leads directly to dyspareunia, which is the medical term for painful sex.
So if estrogen is like the daily maintenance crew for the vagina, keeping the walls thick and the environment acidic, what happens if we just try to, power through without fixing the environment?
Well, this is where we see the physical reality directly overwriting the brain software. Consider the psychological impact of attempting intimacy under these conditions.
Right.
If an action physically hurts, if it causes burning and tearing, the human brain will immediately wire itself to avoid that action. Loss of desire in this scenario is not a dysfunction at all.
It's logical.
It is highly logical. It's a deeply evolved biological response to physical trauma. Your central nervous system is just doing its job. It is protecting you from injury.
That completely reframes the whole issue. I mean, it's infuriating to think about the historical advice women were given to just like have a glass of wine and power through it. If you try to power through, you are literally repeatedly traumatizing fragile tissue.
Yes, you are reinforcing the pain pathway in the brain.
Hmm.
The physical micro tears lead to more inflammation, the infections worsen, and then the psychological aversion to intimacy deepens into this vicious cycle. You simply cannot treat a loss of desire without first rehabilitating the physical environment.
Which brings us to the hormones themselves. Because let's say the tissue is completely healthy. Estrogen might rebuild the physical structure, but what actually drives the psychological craving? The sources point to a surprising culprit, and this goes back to that statistic I mentioned at the very start.
Testosterone.
Yeah. Here's where it gets really interesting, because we always think of testosterone as the macho male hormone. But really, if estrogen is the oil keeping the engine running smoothly without friction, testosterone is the spark plug that actually gets the engine to turn over, right?
I love that analogy. It is arguably the most overlooked hormone in women's health. We have this culturally ingrained idea that estrogen makes you female and testosterone makes you male.
Right.
But biology doesn't care about those labels.
Yeah.
Testosterone is a fundamental female hormone. It's produced by both the ovaries and the adrenal glands.
And it does a lot of heavy lifting. I mean, the clinical data shows it modulates female sexual anatomy, it governs sexual behavior and arousal, and it directly impacts the intensity and quality of an orgasm.
Absolutely. Not to mention its role in your baseline energy, motivation, mood, and preserving muscle mass.
Yet it declines, just like estrogen. The sources map out this steady drop in testosterone levels starting from a woman's mid-20s, naturally plateauing around the time of menopause.
Yeah.
And for someone who undergoes surgical menopause, like having their ovaries removed, that drop isn't a slope, it's an immediate cliff.
Exactly. And when that severe drop leads to a persistent loss of desire, and crucially, when that loss causes personal distress, the guidelines classify it as a recognized medical condition. They call it hypoactive sexual desire disorder, or HSDD.
Wow, HSD.
Acknowledging HSDD as a clinical diagnosis is vital because it validates what the patient is experiencing. It separates the symptom from the moral failing people often project onto themselves. It's a physiological deficit.
I am struggling to square a circle here, though. Let's say a listener goes to their doctor and gets a standard hormone replacement therapy prescription like systemic estrogen to fix their hot flushes and rebuild those vaginal tissues. The British Menopause Society highlights a really counterintuitive problem. Treating the estrogen deficit can actually make the testosterone problem worse.
It can. This is one of the most critical nuances in hormone therapy, and it comes down entirely to the delivery method.
Okay.
If you take your estrogen in pill form, meaning you swallow, it has to be processed by the liver before it enters your general circulation. This is called first-pass metabolism.
Right.
And the liver reacts to that sudden influx of oral estrogen by pumping out a protein called sex hormone binding globulin, or SHBG.
And the sources describe SHBG essentially like a fleet of molecular sponges, right?
That is exactly what it does. SHBG circulates in your bloodstream specifically to bind to free hormones. The problem is, it has a very high affinity for testosterone.
Oh, no.
Yeah. So if your liver is overproducing these sponges because of an oral estrogen pill, they will roam your bloodstream and mop up whatever tiny, precious amount of active testosterone you have left.
That is wild. The very pill you take to manage your menopause could inadvertently trap your remaining testosterone, suppressing your libido even further.
Which is why the clinical guidelines suggest a strategic pivot if a patient is struggling with desire. Switching from an oral estrogen pill to a transdermal method like a patch, a gel, or a spray that you apply directly to the skin bypasses the liver entirely.
So it doesn't trigger the sponges.
Exactly. The estrogen absorbs straight into the bloodstream. It doesn't trigger the liver to overproduce that binding protein, and it leaves your own natural testosterone free to do its job.
Okay, so we've looked at the tissue collapsing without estrogen and the desire flatlining when testosterone is bound up or just depleted. But the medical sources outline a massive third layer to this equation.
They do.
Because perimenopause doesn't happen in a vacuum, right? The surrounding symptoms create this perfect storm that actively suffocates any lingering sex drive.
The biopsychosocial factors. You really cannot evaluate a patient's libido without looking at their sleep architecture.
Right, the night sweats.
Hot flushes and night sweats are notorious for pulling women out of deep REM sleep. You are waking up drenched, your heart rate is spiking, your sympathetic nervous system is highly active.
Basically the fight or flight response.
Yes. And a study highlighted in our research shows that chronic sleep deprivation directly reduces female sexual response. When your brain is constantly forced into survival mode, reproduction and physical intimacy are downgraded to luxury functions.
That makes total sense. You can't feel amorous when you're biologically exhausted.
You really can't.
Then add in the environmental stressors. I mean, the average age of menopause hits right in the early 50s. A listener might be navigating teenagers, pushing boundaries, managing aging parents who need care, all while carrying, like, peak responsibilities in their career.
Cortisol levels are through the roof.
Exactly. So what does this all mean for the listener? If they are stressed, sleep deprived, and taking, well, we haven't even talked about the medications yet.
We haven't, and medications are a huge blind spot for many patients.
Right. Because it's infuriating to realize that the over-the-counter antihistamines you take to survive spring allergy season could be actively compounding this pain.
Yes. Antihistamines work by systemically reducing fluid production to dry up your running nose. But the medication does not distinguish between your nasal cavity and your vaginal canal. It dries out all mucous membranes systemically, worsening the friction and tearing we discussed earlier.
And the sources also flag SSRI antidepressants.
Which are frequently and sometimes inappropriately prescribed for menopausal mood changes. SSRIs function by altering the balance of serotonin in the brain, but a really common side effect is significant sexual dysfunction.
They kill the libido.
They can blunt the nervous system's ability to achieve climax entirely, leading to immense frustration. And furthermore, for patients who have survived breast cancer, treatments like aromatase inhibitors purposefully starve the body of estrogen to prevent cancer recurrence, which obviously induces abrupt and severe menopausal symptoms.
So if the deck is stacked this heavily, I mean, hormones tanking, sleep destroyed by night sweats, medications drying out your mucous membranes, is their libido just doomed regardless of their hormones?
It feels overwhelming, but I reassure you, it is the opposite of doomed, provided you take a multi-targeted approach.
Yeah.
The medical field stresses that you cannot treat this with a single magic bullet. You can't just slap a hormone patch on a deep-seated communication issue with your partner. Conversely, going to couples therapy is entirely useless for fixing a thinning, bleeding vaginal wall. You need a targeted toolkit.
Let's transition into that toolkit then. The guidelines provide a highly specific roadmap for taking back control, starting with non-hormonal over-the-counter options. And the distinction between lubricants and moisturizers is heavily emphasized here.
Yes, people often use the terms interchangeably, but they perform entirely different chemical functions.
So lubricants are strictly for short-term use, right? You apply them during sexual activity to artificially reduce friction, and the NHS guidelines are very clear here. You can use water-based or silicone-based, but you must absolutely avoid petroleum products like Vaseline.
Vaseline is actively harmful in this context. It rapidly degrades latex condoms, leading to contraceptive failure. And petroleum simply isn't designed to be cleared by the delicate internal ecosystem of the vagina. It can literally trap bacteria and cause infections.
Good to know. So lubricants handle the immediate friction, but moisturizers are an entirely different mechanism.
Vaginal moisturizers are designed for actual tissue rehabilitation. They contain bioadhesive polymers, like polycarbophyll, which physically bind to the mucin and epithelial cells on the vaginal wall. They can hold dozens of times their weight in water.
Like a hyaluronic acid serum for your face, but applied to the pelvis?
Very similar, yeah. They slowly release moisture into the tissue over a period of days, and crucially, they are formulated to actively shift the vaginal pH back down to that healthy, acidic level we talked about.
So you don't use them in the heat of the moment?
No, you apply them regularly, usually 2 to 3 times a week, as a baseline maintenance routine.
Okay, that's really actionable. The non-hormonal tools also include lifestyle interventions. Regular sexual activity, whether solo or with a partner, promotes essential blood flow to the pelvic region, feeding those tissues. And then there's cognitive behavioral therapy, or CBT.
Now, CBT is often met with skepticism in this context.
I can definitely see why. If a listener is waking up drenched in sweat, being told to, talk about their feelings sounds incredibly dismissive.
Yeah.
How does CBT actually alter a physical hot flush?
Because it alters the neurological feedback loop. When a hot flush begins, the brain often perceives the sudden temperature shift as a threat. It panics. And that triggers the sympathetic nervous system to dump adrenaline into your bloodstream, which makes the flush significantly hotter, more severe, and more distressing.
Oh, wow.
CBT trains the brain to recognize the flush without initiating that panic response.
Breaking the adrenaline loop.
Exactly. The physiological flush might still happen, but without the adrenaline spike, the severity and the distress just plummet. The clinical evidence shows this dramatically improves sleep quality.
Ah.
And as we established, better sleep restores the baseline energy required for libido to return.
Those are fantastic baseline tools. But for many, especially those suffering from severe GSM, we have to look at clinical hormone prescriptions. Let's start with estrogen. There is a baffling statistic in the guidelines.
Let's hear it.
10 to 25% of women who are already on systemic HRT, like the patches or gels providing estrogen to their whole body, still suffer from severe vaginal atrophy and require localized estrogen on top of it. Why is that? Is it like trying to water a single dying potted plant by running a sprinkler on the entire lawn?
That is a brilliant way to put it.
Mm-hmm.
It seems contradictory until you look at how the body distributes hormones. What's fascinating here is how the local treatments accomplish that targeted watering, to use your analogy. Local estrogen comes in the form of pessaries, creams, or soft, flexible silicone rings, like the S-string.
Okay.
You apply them directly inside the vaginal canal. They bypass the main reservoir entirely and bind directly to the specific estrogen receptors in the pelvic floor.
Plumping the tissue, bringing back the glycogen, feeding the lactobacilli.
Precisely. And because the dosage is incredibly low and strictly localized, there is negligible systemic absorption into your main bloodstream. It stays in the neighborhood.
Which makes it highly safe.
Extremely safe. The guidelines confirm you don't even need to take progesterone to protect your uterine lining when using local estrogen, unlike systemic HRT. Following consultation with an oncologist, it is even considered a safe and vital treatment for many breast cancer survivors suffering from severe dyspareunia.
All right, so the tissue is hydrated and healthy. The pain is gone. But for some, the desire is still missing. This is where we return to the spark, right? The British Menopause Society's guidelines on testosterone.
Yes, if a patient is on adequate HRT, their relationship environment is supportive, their sleep is managed, but their libido remains clinically absent. Testosterone therapy is the evidence-based next step.
And yet the current landscape for getting it is deeply frustrating. In the UK, there are currently no testosterone products explicitly licensed for female use.
It is a glaring gap in women's healthcare. Consequently, specialists must prescribe it off-label. They utilize gels manufactured and licensed for men, brands like Tostrin, Testogel, or Andropheme.
But the dosage is completely different, right? I mean, a listener isn't taking a male dose.
Not at all. A female physiological dose is a fraction of the male requirement, typically around just 5 milligrams a day. You rub a tiny amount, usually a pea-sized drop, onto the skin of your lower abdomen or outer thigh.
The sources are very careful to manage expectations here, though. You don't apply the gel on a Friday morning and expect a wild Friday night.
No. The timeline requires patience. It takes 8 to 12 weeks to see clinical improvement.
Why does it take a full 3 months? How does the body process that hormone after being deprived of it for so long?
It comes down to cellular mechanics. Because the body hasn't had adequate testosterone, it has literally shuttered the factories. It has downregulated the androgen receptors. When you reintroduce the hormone via the gel, the body has to physically build new receptors from scratch, insert them into the cell membranes, and begin transcribing new proteins. It is a slow, structural rebuild.
And the guidelines mandate blood monitoring during this rebuild. You need a baseline test before starting, and follow-ups at 6 to 12 weeks to ensure the levels remain strictly within the normal female physiological range. We are replacing a deficit, we're not creating an excess.
Exactly. And provided the levels stay within that normal female range, adverse side effects such as acne or unwanted hair growth are rare and generally reverse if the dosage is lowered.
This entire deep dive really recontextualizes the aging body. I mean, if you are listening to this and your libido has vanished or sex has become something you literally dread, the clinical evidence is clear. This is a very real, very physical result of declining hormones, compounded by the exhaustion of midlife. It is not in your head.
It is not, and you do not have to just endure it. The concept that women should simply put up with painful sex as they age is an archaic, unacceptable mindset in modern medicine.
There is no normal amount of sex you are supposed to be having. But if you are distressed by your lack of desire or experiencing pain, you have every right to seek help. Take these specific insights, ask about vaginal moisturizers, push for a discussion on local estrogen, and inquire about testosterone therapy if you fit the criteria. Advocate for your quality of life at your next doctor's appointment.
This actually raises an important question about the resilience of human biology, and I want to leave you with one final mind-bending concept from the research.
Oh, please do.
It's a field of study called endocrinology.
Endocrinology. Tell us about that.
We've talked extensively about delivering active hormones,
Hmm.
but there is a localized treatment called vaginal DHEA or progesterone. Now, DHEA is a precursor hormone. By itself, it is completely inactive. It isn't estrogen, and it isn't testosterone.
So what happens when you introduce it to the vaginal tissue?
When you insert this precursor, the vaginal epithelial cells absorb it. Because these cells evolved to survive, they still possess the dormant enzymes necessary to convert that DHEA into both active estrogen and active testosterone internally, right there inside the individual cells.
Wait, really? The cells are manufacturing their own active hormones on demand?
They are. The cells pull the precursor inside, synthesize exactly the amount of estrogen and testosterone they need to rebuild the tissue and restore sensation, and then, and this is the truly brilliant part, they deactivate those hormones internally before they ever leak into your main bloodstream.
That is incredible. Your body literally turns your vaginal tissue into a microscopic, self-contained, self-regulating hormone factory.
It proves that your body isn't broken or obsolete. Sometimes it simply needs the right raw materials to reopen the factory doors.
What an empowering place to end. I mean, if estrogen is the structural foundation of your house and testosterone is the electricity that makes you actually want to live in it, you now have the blueprint to rebuild both. Keep asking questions, keep advocating for your health, and keep diving deep.